Okay, thank you very much for the invitation to come and speak here, and I look forward to sharing some of the work that we're doing on the SONNET study. So just to explain what I'll be talking about today, first of all, I'll explain what we mean by social connection, the topic of this talk, why it's important in care homes and for all of us, what we know about how we can improve it at the moment, but where there are limitations in that research. And then I'll introduce some of the initial findings from our study. So our focus has been on the concept of social connection. We use this as a broad term, which encompasses all aspects of human relationships and interactions. Those are objective and subjective constructs. And part of our work was, when we started this study, was to think about what we should really take into account. So this figure we generated to reflect this. You can see that we've thought about social aspects that are experienced, areas like feeling lonely or feeling socially connected with other people, and concepts that might be more observed by other people, like how many people we have in our social network, how often we spend time with other people. So that hopefully grounds us in terms of what we'll be talking about today. So I hope we'd all agree, really, that social connection is an essential human need for all of us, and has particular importance in people living in care homes, something really born into focus during COVID and the enforced isolation that many experienced. First of all, it's really important for improving quality of life. There's really strong evidence that lower levels of loneliness or lower levels of social isolation are linked with better mental health, better physical health, and also lower risk of developing dementia, better cognitive function for residents. And having good social connection in a care home setting is particularly reflects really good quality care. It's something that we've already heard about today from Judith and other speakers. So to come to the point that social connection is essential in care homes. But evidence suggests a range of different studies that loneliness is a common experience for care home residents. So the figure here is wide. You can see somewhere between 40 and 70% of residents report some level of loneliness. And we'll come back to why that's such a wide variation in a moment. So residents living in care homes have some specific considerations compared to those in the broader community. Most care home residents are older adults, might experience sensory impairment like visual or hearing loss. Cognitive impairment is common, and mobility difficulties. The interaction with families differs when someone moves into a care home setting. So many provide vital social support for residents once they move into a care home setting, but otherwise some residents don't have a close family who can be involved in their care. Staff play a really essential role in ensuring good social connection for residents, but we know that time is limited, resources are limited, and sometimes there's high turnover. That means that there is inconsistency in the way that social connection is maintained with staff members. And homes are communal settings. They group meals, group activities are a really key part of the activities and social engagement that people take part in. Finally, the interaction in the way in which different care homes interact with communities differs across different settings. Just to touch on another specific point, some work that we did looking at care home residents with dementia, spread across a very large number of care homes across the country, showed that a relatively large proportion of care home residents have experienced apathy at some point during their experience. So around half of residents in this study had some level of apathy at some point during the 16 months that we followed them up, although that was often fluctuating. Many residents never experienced that, but some did. And that, again, that would just suggest that engaging socially is something that some residents really need support to do, because they might not have the ability to initiate that themselves. So to go on to talking about what the evidence suggests at the moment, there is a reasonably good body of research that has tested the effect of interventions on various outcomes of social connection. These might have looked at, and I'll touch on some of these in a bit more detail in a moment, some individual level interventions. Those might be reminiscence, facilitated video calling with family members, the way in which different community level and home level characteristics like staffing or the size of an institution affects or is associated with levels of social experience for its residents. And clearly a focus during COVID-19 about the potential strategies that might improve social connection during that time. And our partners in this study from Toronto in Canada have done this nice work summarizing some of the work that's been done in the past. So I'm going to just focus briefly on one review that looked at what sort of interventions in care homes might improve, might have an impact on loneliness. And this study summarized 4 different groups of interventions and found variable findings. So what were considered to be animal-assisted therapies, so that might be having real animals coming in, or the sort of robotic animals like the cute robot seal that's used. Those have been tested, and to some extent the experience of having animals visiting a care home was linked with better levels of loneliness, but clearly how acceptable this was really varied. As you might imagine, some residents really didn't like this experience. Residents who were used to having pets had better experiences with animals who visited, and those who maybe hadn't made a choice to have pets during their earlier life didn't enjoy this so much. Probably a more interesting area is the contribution of group activities. So often these were cognitive training sessions that were held in care homes, reminiscence therapy groups, 4 studies that were found looking at these areas, and the findings were quite mixed really from as to whether those improved people's experience of loneliness. The use of digital technologies, by that the authors mean facilitated video calling with family members, on the whole were linked with lower levels of loneliness. And one study assessed the effect of Eden philosophy, so a person-centered care philosophy on experiences of care home residents, and that wasn't linked with lower levels of loneliness. So really quite mixed findings here, I think. I want to touch on the fact that social care is something that's provided in everyday, has the opportunity to be provided in everyday care, but the way in which this is delivered is variable, and there's some research which is in some ways quite troubling for the way in which social contact is supported during routine care. This is an old study. This is about 15 years ago from 2 large US nursing homes, and they videotaped personal care provided in care home settings and tried to analyze the nature of the interaction between the staff and residents. There was a detailed kind of ethical process involved in setting this up and people's awareness of what was happening within this. But the findings suggested that the level of social contact during routine personal care was really very variable. There were some areas where there were, for example, acknowledging or reinforcing or chatting or personal supportive social contact during those interactions, about 50% of the time. But often, the only interaction that was taking place during this particular study were command instructions, verbal prompts, just asking people, giving people directions to support the provision of personal care. So again, I'd emphasise that this is 2 nursing homes. This is some time ago, but you can see that there is the potential that an opportunity for social contact is overlooked, really. Just a few other areas, just again, I suppose supporting the potential impact of social interaction in care homes on various different aspects of residents' experience. This is a study from a drug trial, but where they looked initially at the impact of some different aspects of care that were provided and seeing the impact that social or environmental modifications or music might have on levels of agitation. And it might be difficult to see, but the one that had the largest improvement in agitation was the social interaction that was provided. I think immediately going back to Judith's talk about intergenerational care, social interactions are ranked as providing the greatest level of pleasure for residents. So here, a list of different potential sort of interactions. There's an animal, toy, watching a video, having one of these robot animals coming into a care home, all ranked. And the one that had the biggest impact on affect, enjoyment, was having real children coming into the care home, socializing with a research assistant, having pets come in were also quite high up on that list as to the things that provided the greatest level of pleasure. And the final example here to really emphasize the point that social interaction is really important is that the social intervention here in this study was linked with the lowest risk of people developing agitation. As long as you're able to provide good social care in care homes, then agitation is less likely to occur. But I want to say that some of this research evidence is quite challenging to interpret. Often, and lots of the studies I just showed there have very short follow-up, so it's unclear whether interventions have a lasting effect. Terminology that's used is quite inconsistent. I've probably done so already in the talk so far, but how we describe loneliness, how we describe social connection, social engagement it can often be done in an inconsistent way. So the figure of 40 to 80% of residents experiencing loneliness, that variation is probably not because there is true variation, but because loneliness can be characterized in different ways. And part of this is because many measures, and that means questionnaires, tools, lists of questions that try to assess whether someone is experiencing loneliness or engaging socially, haven't been developed or tested for care setting. And that's where our study comes in, because we recognized that there was no consensus or gold standard approach to how we should measure social connection in care homes. So what we wanted to do in our SONNET study was to try and improve this, so to try and facilitate better research on social connection in care homes, potentially better clinical practice by improving the measurement of social connection. So SONNET, I have at the bottom here, is SONNET stands for Social Connection in Care Home Residents. We formed that into the acronym SONNET, but it's a study that we're conducting with colleagues in Toronto, in Canada. And our aim was to try and develop a measure that should be suitable for observational interventional research, the sort of studies that I've presented already, and potentially have utility in real-world settings. So our aim was to do three things, and we're two-thirds of the way through this really, which is that we wanted to identify what measures were available in existing research and what their psychometric properties were. That means how accurate they are at measuring social connection. We wanted to find out from qualitative interviews what care home residents, families, clinicians, care staff, and researchers consider to be important for social connection in care home residents. And that also means finding out what helps and hinders social connection in those settings. And then develop and test our new measure to see whether it can adequately assess social connection. So that's summarized in this image here. First of the two areas, the appraisal of existing measures and the discussions, the qualitative interviews with important stakeholders together helped us to develop the measure, and we're in the green phase at the moment, as I'll explain in a moment. So I'm just going to touch on the findings from each of these. It will be a whistle-stop tour, but I'm happy to answer questions or discuss at a later point. So for this review of existing measures, we wanted to do two things. One was to use this very detailed methodology called COSMIN to help identify what the quality of existing measures were, and then to describe and analyse what those measures, those questionnaires were trying to assess. So in brief, we looked at 8 databases up until the middle of last year for studies which had looked at assessing social connection measures that had been used in care home residents. And there's a little more detail on the methods that we used for each of those analyses, but essentially the COSMIN review, which I'll give findings for in a moment, looked at how reliable and valid the measurements were, and the content analysis looked at what they were measuring. So our initial search found 9,000 potential reviews. We and the team looked through these and found 38 measures, the majority of which, I'll just point to the middle point here, the majority of them measured quality of life or well-being or another kind of area of well-being, but only had a question or two on social connection. The long list is there. And crucially, the work here led by Hannah and Neha, found that, to go to the bottom point, that very few of these 38 measures had actually looked in any detail about how accurate the measures were. So none of them could be recommended for use. So that left the opportunity for us to go on and do the rest of our work. I'll just say that, again, most of these measures were quite non-specific in what they were trying to measure. So they would often, an example being a measure of social engagement, which actually touch on various different areas of social connection, summarised in the slide here, which I can. Okay, so I want to just talk briefly about AIM 2. So this is our qualitative interviews, which we did across care homes here at Hammerson, but also care homes across the country, and lots of interviews over in Canada with a mix of different participants. And we asked people their views on what was important for their social connection and how it should be measured. And this was summarised in a thematic analysis. And I'll just orientate you about this. So the points on the right here are the things that people said were important for their relationships and their social connection. So obviously there are activities, meal times, activities in groups or on their own. The experiences of verbal and non-verbal interactions. And just the point at the bottom here is one that really struck me during interviews, is how important residents place their relationships with staff members and volunteers. And work that we're doing at the moment is looking to see which factors helped and hindered people to have that good social connection. And there's a list really on the left of resident characteristics, staff characteristics, and care home characteristics that help that. So I'll just say that we then went on and to take those points from our review and from our qualitative interviews into the development of our new measure, which we ultimately thought should prioritise social engagement, activities and relationships, and also the experience that had for residents in terms of their social connectedness. We wanted to develop a questionnaire that could be used, answered by the resident themselves or by someone who knows them well, because we know how important it is to get the insight directly from residents, but obviously some residents might have conditions that make it more difficult for them to answer accurately. We made a long list of 70 questions and have gradually reduced that to 20 items, and I'll just show you a couple of questions here from our scales. This is something, there are 20 of these questions at the moment, but we'll cut that down further. At the top, an example of how often do you leave the care home to spend time with people outside the care home, and residents can answer one of those options, and if they find it difficult to answer, from never, sometimes, often, or very often, they could say yes or no to that question. And a similar list of questions for informants, for care staff to answer. And just finally, we're now testing this scale in care homes across the country and in Canada. So speaking to lots of care home residents and staff members who can answer questions on their behalf. Residents provide information about themselves, give some answers about cognition, activities of daily living, or neuropsychiatric symptoms. They complete our scale and also receive a gift voucher as thanks for their time. Too many button clicks, we will then, our work at the moment is thinking about analysing this to shorten the scale and test how accurate it is. I'm sorry I can't share the answer to that at the moment, but we'll have that soon. So just to sum up, that social connection is essential in care homes, linked to better mental, physical and cognitive health, and a key component of good quality care. There's some evidence that individual and group interventions may improve social connection, but the evidence is limited, amongst other things, by there being no good way of measuring this at the moment. So our study is trying to produce a conceptual map, a figure of what social connection should be, a detailed list of the measures that have been used in the past and how accurate those are, an understanding of what are the barriers and facilitators of good social connection, and work in progress is our development of a new person-centred measure. So acknowledging the huge work of our team and our funders, I want to say thank you very much and look forward to answering any questions. Thanks.